I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series. I love doing these informative webinars as I'm also a patient living with MPA vasculitis. And today's webinar is actually a follow-up to our recent webinar with Dr. Koreishi on the topic of eyes and vasculitis. We're excited to have him with us again to answer some additional questions that came up when we ran out of time in the Eyes and Vasculitis webinar. So before we get started, let me introduce him. Dr. Anjem Koreishi is an assistant professor of ophthalmology at Northwestern University Feinberg School of Medicine. Welcome, Dr. Koreishi.
Thank you, and thank you for having me back.
And at this point, I'd like to ask you if you have any disclosures before we get going.
I do not have any relevant financial disclosures.
Okay, great. Then let's get started today. We had such a great webinar with you, and we have some additional questions that we promised to answer. So I'm just going to go ahead and dive in. And the first one is, what's the difference between an eye infection and an eye inflammation? And if they're different, how does the treatment vary from inflammation versus infection?
Sure. So inflammation is something, for example, if you bang your knee and it gets swollen, that's inflammation. But if you get a cut and it becomes red and you get discharge from there, that's an infection. An infection almost always causes inflammation. So infection will have inflammation with it. However, inflammation itself does not have to have an infection. Infection is caused by a bacteria or virus or an organism like that, whereas inflammation is just your body's reaction. With these conditions that we're talking about, these vasculitic conditions, they always cause inflammation, right? These are autoimmune conditions, so we always deal with inflammation. In some cases, we can have superimposed infection on top of certain conditions. The treatment for inflammation, steroids and immunomodulatory medications like adalimumab and infliximab and rituximab. Treatment for infection revolves around antibiotics or antivirals, and eventually maybe something like steroids. Some physicians will treat with steroids while treating for an infection if there is a lot of inflammation. It just depends on the situation. So basically, infection is caused by viruses or bacteria or other organisms that cause more of an aggressive reaction that needs to be treated with antibacterial or antiviral medication. They often cause inflammation. Inflammation, however, is much more common and is what we are mostly concerned with these type of conditions.
Okay, and just so I can be clear, I understand infection and treatment of infection. And with inflammation as a vasculitis patient, is that something that you treat or you watch?
Well, so inflammation in a vasculitis patient, we do want to treat. So when we see inflammation on the eyes, like the conditions like scleritis or retinal vasculitis that I mentioned, or inflammation in the kidneys in some of these conditions, this all definitely needs to be treated. An infection also definitely needs to be treated, just a little bit different approach because you need to attack the organism that is causing the infection. Okay,
I see. And I have a little bit different question for you. One patient asked this question, thought that their doctor diagnosed uveitis, but maybe missed GPA. So I think the basic question is, what should we do to make sure that the doctor is familiar with vasculitis?
Yes, absolutely. Just as a baseline, things like retinal vasculitis and these vasculitic conditions are not extremely common. So while many doctors know of them, they may not have experience treating them, especially just dependent on where you are and the type of ophthalmologist you're seeing. I think that uveitis specialists should be well versed in the world of vasculitis and these vasculitic conditions like GPA, GCA, PAN, etc. That said, even in a world of uveitis specialists, sometimes the specific diagnosis is very difficult to make when it's not straight out of a textbook. Sometimes the testing that we do can come back negative, clouding the picture. So I think making sure you're comfortable with the doctor, you're comfortable that they're doing everything they can and not complacent with the situation is an important step. Talking to other physicians, if you have involvement in other parts of the body, that collaboration can be important. And also, I don't think it ever hurts to get a second opinion as a patient, right? These are your eyes, this is your body. I think that most of us as physicians are very comfortable and oftentimes encourage second opinions. The more minds, the better. I think that if a doctor is hesitant for you to get a second opinion, to me, that's potentially a red flag. So I think that just having other minds and other opinions always helps. The other kind of things that are plus or minus is, searching them online and seeing what their specialties are. The reason I say plus and minus is some excellent doctors just don't have an online presence. So just making sure that you meet them, talk to them, ask them how many patients with vasculitis they've had, make sure that you're comfortable with those basic questions, I think is the best route to go.
Well, speaking of basic questions, this is one that I get very confused with the different types of eye doctors. And I think all vasculitis patients at one point or another, their doctor that's taking care of them usually says, we need to keep an eye on your eyes, so make sure you get regular eye exams. I'm not sure I know exactly which type of doctor to go to the first time, the difference between an optometrist, an ophthalmologist. I've even heard of an orthoptist and a neuro-ophthalmology. Where do we start? What kind of doctor do we go to, or what do we need?
Yeah, we could even add in more subtypes of ophthalmologists, like the uveitis specialist and the retina specialist and all that, just to make it more confusing. So essentially, the ophthalmologist I'll keep for the end, because the neuro-ophthalmologist is a subtype of either a neurologist or ophthalmologist. And me as a uveitis specialist, I'm a subtype of ophthalmologist. So I'll explain that at the end. Orthoptist, I'll start with. So these are people that typically work with the pediatric population when we have eye movement issues, such as an eye drifting out. So they work with prisms in different ways to alleviate double vision or issues, with what's called exotropia, the eye being out, or esotropia, the eye moving in. So they oftentimes just work in conjunction with optometrists or ophthalmologists more in the pediatric world, or those with eye movement issues. An optometrist is a very, very common type of eye doctor. They go to optometry school. They are extremely, extremely well trained in glasses, contacts, refractions, meaning ways to kind of improve your farsightedness, nearsightedness, astigmatism, contact lenses, things like that. I personally think that they are way better than us as ophthalmologists in doing that. They are also trained on medical issues of the eyes, up until they get to a certain point. So for any patients with vasculitis, and especially any active issues with vasculitis, I do not think an optometrist is sufficient. I think even a general ophthalmologist probably is not sufficient. But an optometrist will play a big role in the care of your eyes in terms of helping with glasses and contact lenses and things like that. Depending on where people are, an optometrist, especially a really good optometrist, can be the person that initially sees your symptoms and says, hey, you need to go see an ophthalmologist, or let's do these couple tests and have you see an ophthalmologist. So they definitely can play a role in the diagnostic pathway. But then once things are diagnosed as vasculitis, their management role of the disease is typically left to the ophthalmologist. So optometrists, really good for glasses, contact lenses, astigmatism, things like that, and for initial medical diagnosis and medical management of more milder diseases. Then we move on to ophthalmologists. So ophthalmologists, we are MDs, went to medical school, did our residency in ophthalmology. Those of us that have subspecialty training, like myself in uveitis, do further fellowship training after that. A neuro-ophthalmologist, again, can come from ophthalmology or from neurology, and they do further subspecialty training in neuro-ophthalmology. There's retina specialists as well, which are more common than uveitis specialists. They may be somebody that can be part of the team managing retinal vasculitis, if anybody has that. If anybody had issues with blockages in the retinal blood vessels, you're probably seeing a retina specialist as well. And then anybody that's run into issues with eye pressure or glaucoma related to steroids or other issues may be seeing a glaucoma specialist. And these are all different types of ophthalmologists. So the ophthalmologist is going to be responsible for more specifically diagnosing and managing the eye disease, whether it's related to the vasculitis or not. Working and collaborating with the team, the rheumatologist, the ENT doctor, if there is one, et cetera, and really kind of taking the forefront of what are the medications, what do we need to be doing for the vasculitis overall. So the ophthalmologist would be more the kind of medical, surgical person who collaborates with your other physicians. The optometrist would be more the kind of glasses, contact lenses type of person. And orthoptist, most adults wouldn't need unless you have double vision or issues with eye movement, which can be an issue with vasculitis. I know that was kind of a rambling answer, but hopefully that made sense.
No, I actually think that was a great answer. I think the question for me as a patient would be that if I have MPA vasculitis and my doctor did tell me early on that I would need regular eye exams, would I, because of what you just said, would I start looking for an ophthalmologist who's familiar with uveitis, a uveitis ophthalmologist, or just a general ophthalmologist and say, I have vasculitis and I'm here just to make sure everything's healthy with my eyes? Is that where I start?
Yeah, it's tough because a lot of it just depends on availability and access as well. I think if you have been diagnosed with vasculitis, have never had eye issues, and the vasculitis is doing well, then, I think honestly a good optometrist is probably okay, but ideally at least a general ophthalmologist. That way they're more in tune to looking for specific findings and can refer you if they do find anything. It is not as likely, after the fact, a handful of years later, to start developing eye issues, with the exception of things like cataracts, which would be caught by an optometrist or a general ophthalmologist. Somebody that has had eye involvement, whether it's retinal vasculitis, scleritis, anything like that related to vasculitis, and even if it is quiet later on, those people I would recommend to see a specialist that is well versed in vasculitis, because you want to be paying attention to minutia in those situations. And especially when anything is active, you want to be seeing, a uveitis specialist or someone who is well versed in these conditions.
Okay, thanks. I think that was a great answer. I understand it now, and that's a good thing. One of our other questions was an EGPA patient that had a retinal occlusion that caused blindness in one eye. Would there be a tendency for further issues in that eye or the other eye? How does that work?
Yeah, this is a good question, and it's a scary question for a lot of patients that suffer from loss of vision in one eye. My answer is that if a person has had, it sounds like a retinal artery occlusion, if it causes loss of vision, significant loss of vision, that there is some predilection for the disease attacking the retinal blood vessels. And the key is to make sure that overall the disease is well treated, and that is going to reduce the overall risk. I do not have any data to say this, but my inclination is a patient that had a retinal artery or retinal vein occlusion related to vasculitis is more likely to develop that again than a patient with the same condition, EGPA, that did not develop a retinal occlusion, retinal blood vessel occlusion. But that said, the key in either situation is to make sure the disease overall is well treated, and the doctor that you're seeing, if it's a uveitis specialist or a retina specialist, maybe once a year or something, can repeat the test I'm sure you had called a fluorescein angiogram, where they look at the retinal blood vessels and to make sure that there's no evidence of anything milder cropping up before it happens right in the center of the eye and causes loss of vision.
Okay, good advice. The next question, I don't even know what this is, but could you please explain vitreomacular traction?
Yes, so I think the question was that is this more common in patients with vasculitis? So I'm gonna do things with my hands here. Hopefully this makes sense. If for the people that had seen my other talk, if you remember, I should put a scan up of what's called an OCT. This is this cross-sectional scan of the retina, and it kind of was a cross-section with a little dip in the middle like that, okay? So basically the top of it came across and dipped down like this. So the inner part here is the inside of the eye. That's that jelly called the vitreous where people get floaters. Now, vitreomacular traction or vitreomacular adhesion is when the back face of that vitreous jelly, it doesn't peel off of the surface of the retina well enough. So it sticks to the retina and it tents it up and it pulls the top of the retina up. And that can cause some visual issues. Typically, this is unrelated to inflammation in the eye or vasculitis. This is something that can happen just by chance in any patient. There are, some thoughts that in patients with uveitis that it can be more common because it can make some of the surfaces a little more sticky, but I have not seen an increased rate of that with vasculitis. That's something that a retina specialist would follow most of the time. Nothing needs to be done about it unless it's very aggressive and it keeps pulling the retina. Then they would need to surgically go in and just release that adhesion. Basically, that's more of a mechanical or anatomic issue that can happen, not something that happens directly as a result of these inflammatory conditions.
Okay, and that one was way over my head, but thanks for explaining it on a level I could understand. The next question is my question, but I was talking to somebody else about this recently that is also a vasculitis patient. I've recently had, about a year ago, had cataracts removed and had my new lenses implanted, and I'm very happy with my eyes right now. But does somebody who has inflammation or eye inflammation due to the vasculitis, are they more likely to have cataracts? Is it more likely that they will have complications getting the cataracts removed? Anything like that due to the vasculitis?
Yeah, so good question. And one of my topics that I give a lot of talks on is cataract surgery in patients with uveitis. So I'll backpack off of that a little bit with some of the philosophies of that. So essentially, yes, cataracts are more common in patients with vasculitis, in patients with any autoimmune disease. And the reason for that is steroids. Steroids through any route will increase the rate and make it happen earlier of cataract formation. It also tends to form a type of cataract that is a little more visually significant than the typical age-related cataract. And that's just the part of the lens, the natural lens that becomes cloudy is a little bit different. So definitely is more common. For patients that have uveitis, it is even more common because inflammation inside of the eye also contributes to cataract formation. So the answer to that question is a definite yes. Cataracts are more common. They happen earlier age-wise and a little bit more rapid progression in patients with vasculitis and other autoimmune conditions compared to the average person. In terms of the actual surgery, if somebody has had a lot of injections into the eye for any reason, that can potentially weaken some of the structures. And if somebody related to vasculitis has had scleritis or keratitis, the inflammation of the cornea and the sclera that we had mentioned, which are really the most common areas of eye involvement with a lot of these vasculitic conditions, that can be important in making sure that the approach to the surgery and how the doctor is approaching it is optimal. And that's just something you can specifically ask them, related to my eye, to my condition, what will you do differently for me? And I think that's a key question. For me, a patient that has had, and this goes to risk of complications, normally I would not see any increased risk of complications. I think overall cataract surgery is still very, very safe. After surgery, however, people that have had inflammation in the eye, so whether that's retinal vasculitis, scleritis, keratitis, orbital inflammation, even anything around the eye, I always assume that there is going to be increased inflammation after cataract surgery. So one thing we want to make sure is before cataract surgery that any inflammation in or on the eye has been well controlled for at least 3 months. That number is taken from the uveitis world, but I apply it to anybody that has inflammation in the eye. So 3 months of inflammation being well controlled before doing surgery. And usually we will give increased steroids around the time of surgery just to help prevent any recurrence or flare of the inflammation in the eye after cataract surgery. So the main thing is making sure that the eye disease is quiet, meaning no inflammation, and asking the doctor, what steps will you take differently in my situation versus the standard situation? If you've never had inflammation in the eye, that answer may be nothing. If you have inflammation in the eye, it is oftentimes worthwhile to do what we call perioperative steroids. And depending on who you're seeing, they may feel that's not necessary. And it may be worth asking, hey, do you think you could just reach out to a uveitis specialist just to get their opinion on that? You know, it doesn't mean that they shouldn't do the surgery. I co-manage other surgeons' inflammation regimens around surgery as well. So I think sometimes that can help as well.
Okay, great. I have one more question, just as if it's just me. I'm a new patient. I have eye involvement. What questions should I think ahead of time to ask you as the doctor? What's important? What do you want your patients to ask you?
Yeah, this is a very important question, and I know I'm probably gonna miss some things that are always important because there are specific situations where different answers are right. You know, we went through already making sure that you're comfortable with the doctor, so asking questions more on the doctor's side. And I think this goes towards more on the patient side to make sure that any issue is addressed. So I would want to ask first, you know, from the doctor's side, how many patients with vasculitis have you treated? What are your typical medication regimens that you go to? Do you collaborate frequently with other doctors, rheumatologists, et cetera? And how easy is that collaboration? Especially in a private practice, oftentimes academic centers, that collaboration is much easier. I think that making sure they feel comfortable with examining all parts of the eye is important, and that comes with, you know, being a uveitis specialist, for example. You can get inflammation in the retina, in the sclera, in the cornea. And again, if you see just a retina specialist, they are not as well versed with the front of the eye. So getting in with somebody, I think in my mind, I may be biased, but a uveitis specialist where we are well versed in kind of examining all parts of the eye, that is important. So making sure the doctor is well versed in evaluation of the retina as well as, you know, subtle issues elsewhere. And again, most general ophthalmologists will be well versed in looking at those areas, maybe not treating and managing them, but that's what you need initially. And you know, if you're first going in, I think as the doctor goes through some of what we call review of systems, which is talking to you as a patient about different parts of the body that are involved or different issues that you have, this is where I think it helps for you to know the disease well, because I know plenty of really good ophthalmologists that just don't routinely ask those questions outside of the eye. So for most of these vasculitis, vasculitic conditions, We want to know about headaches, about double vision, about nosebleeds, about sinus congestion, about coughs, rashes, joint pains, darkness of urine, things like that. That, again, most ophthalmologists are not going to ask about those unless it's a good uveitis specialist where we're used to doing that. But even just mentioning that and running through all of that with the ophthalmologist can be helpful, because it kind of tunes them into the condition that's going on as well. From the eye itself, again, I mentioned double vision, floaters, blind spots in vision, pain and redness. These are all things that you do want to bring up, even if you're not directly asked about them. Yeah, go ahead.
That's all fascinating. I just want to empower patients like me to be able to ask their doctor those questions and tell them those things, because we often think the doctor knows everything and that we are insulting them by telling them things about ourselves like this. But you're saying it's the opposite of that, and we really do need to bring this up.
I think so. And I will say it does depend on your doctor's personality, whether you're going to annoy them by doing that. And honestly, in my opinion, the doctor should not be annoyed by gathering more information that is relevant. If you're going, if you start telling a story about 20 years ago when you got hit in the knee with a soccer ball, that could be a different story, right? But things like this that are relevant, I think, are important for us to know. I often joke, I hope this, if this comes across as inappropriate, you can edit this out. But I often joke that now in 2023, right, this is not the 1950s Mad Men style of medicine where the doctor is the god and the patient has to listen to the doctor, right? This is collaborative medicine where it's a partnership between the doctor and the physician. We likely know more in terms of, well, we should theoretically know more in terms of the disease process, the management options, the diagnostic options, and things like that. But it's our job not to tell you what to do, but explain the options to the patient, because there oftentimes are multiple options that can be appropriate that may fit into different patients' lifestyles differently. So I really do think that that collaborative approach and being open and conversational with your physician about this is important. And I think starting that conversation with, I don't want to overstep or be annoying, but I heard a talk where I was told it would be helpful to just explain some other symptoms in these type of conditions to you, and I hope that's okay. Just kind of saying something like that oftentimes just reduces the guard of the doctor, where they're not going to think that the patient thinks they know more than me, but more the patient is trying to help us both in this partnership. So
that's great advice right there. That is empowering. That does make it so that as a patient, I feel like I can talk to my doctor. Sometimes it's just knowing the right words to get it started. So
yeah.
And we all hope we have a doctor like you, Dr. Koreishi, who will listen to us and help us, guide us through the process instead of I sometimes feel like when I speak to a doctor and I say, and I have vasculitis, that I get like this blank stare, like, okay, that has nothing to do with why you're here today, but it always does have something to do with it.
Yeah.
So we appreciate your time so much today. I thank you. We had these extra questions. We promise we always try to get a second webinar with all the questions that came up that didn't get answered. And I just can't tell you how much we appreciate you giving your time today, and the Vasculitis Foundation, of course, for following up and making this available on their website. So the first webinar that you did is up on the vasculitisfoundation.org website. And now this one will be shortly, as soon as we get it prepared and ready to go up. But thank you so much for your time. Is there any last thing you feel like you'd like to add?
No, I don't think so. I think just going on the last topic again, don't make any decisions based on your concern of how somebody else may feel. Stick up for yourself. You're the patient. This is your body, your eyes. And I do think that with some of these conversations with the physician, just putting in an icebreaker. I've talked to other vasculitis patients, and I just want to make sure that we address everything. Please tell me if I'm overstepping or something like that, just to it lightens up the doctor a little bit, even the ones that maybe, a little bit of the tight collar type of people. It'll lighten them up a little bit, and more likely to get a good relationship and good answers for you in your care.
Again, great advice. Totally appreciate it. Thank you so much for your time today, Dr. Koreishi.
My pleasure. Thank you for having me back.